There's no such a keyboard. Okay, so introduction to geriatric oncology. Show of hands, have any of you all rotated in geriatric clinic? I think only the older ones, and the new batch we have not managed. Okay, so it's on full screen or slightly. Okay, so this is the outline as so age cutoff. How many anybody knows what is the age cutoff that we use for geriatric oncology globally? India.
Global 70 years.
Global 70, matlab? All everywhere other than India, like pan world other than India is 70.
SIOG is 70.
Sorry, SIOG is 70. You have seen my presentation, then you're not allowed to talk. Sorry, of course you're allowed. So other everywhere else it's 70, is that what you're saying?
ASCO is 65 in US.
Perfect. So US, Europe. Deep was vigorously saying something. What were you saying? You just now said SIOG. Where is SIOG located? वो तो European organization है ना? 70, yeah. So this is the ASCO guidelines, and as you rightly pointed out, ASCO says 65. So WHO, I think traditionally through the years we have said that 65 is the cutoff for older age. So ASCO follows that, and they recommend that all patients 65 and over should undergo geriatric assessment. SIOG says 70 because there are the people in Europe and the high income countries are older, right? They have a better life expectancy. So that says 70. Sorry. NCCN has a little bit of a nuanced view. So they say age 65 is generally considered the chronologic age for an older person, but you need to assess the patient and do a physiologic age. So what does this depend on? Right? The cutoff for calling a patient, calling a person old. It depends upon two things. One is the life expectancy, that I can't answer. I've already shown this to you. So at the bottom, you can see this is the color coding, and the rightmost is the oldest. So the people who live the longest, which is Hong Kong, some of Australia, Canada, and some parts of Europe. So these are the people who live the longest. So an older person in these places would be older, right? So that cutoff would be older. India falls around here. So in this kind of category, around late 60s to early 70s. What is the other factor that plays into when we call a person old? Anybody?
Age of retirement.
Sorry?
Age of retirement.
Age of retirement, exactly. And that's perfectly correct. So think back to your family also or in society. So when somebody retires, the retired person is considered older, right? So that is usually when somebody retires, a lot of social processes, a lot of things in their life change. Right? They stop going to work, they are at home, they take care of their grandkids, they go to temple, all of that. So that is the second cutoff. So our life expectancy overall is globally 74 worldwide. Women always have a longer life expectancy than men, so globally as well as in India. India's life expectancy is not far behind global, so it's 72 years. And then we feel, we have a good life expectancy. So I put up the top 10 countries in the world life expectancy. So Hong Kong 85, Japan 85, Singapore 84, etc. So definitely we are somewhere in the middle run in terms of life expectancy. And retirement age, and India retirement age is 60. So therefore, we use a cutoff of 60 in India, and that's been used in other institutions as well. So this was done at AIMS. So they also use 60 and over, patients 60 and over. And in our geriatric clinic as well, we have used 60 and over. Okay, so how common are geriatric patients in practice? Not true. Anybody else? First years or second years? Or third years or anywhere?
60 to 70%.
Sorry, 60 to 70%
Are geriatric patients
in with cancer. And does everybody agree? So that you are saying that out of every 3 patients, 2 of them are geriatric. Is that your experience?
30 to 20.
The bonus saying 20. 20 to 50. That's bada sa range. 20 to 30. Perfect. Yeah, so it's actually more in the 20 to 30 range. Aditya, which clinic are you rotating in now? So, sorry? And actually, then you are actually correct. So in our hospital registry, 70% of patients with prostate at least are 70% are older. So you are absolutely, then you're bang on. So this is not in terms of people with cancer. So generally 8.5% of people worldwide are 65 and older. And that proportion is increasing. So it's expected to jump exponentially. So this is called that geriatric tsunamis. Yeah, you might have seen this, a silver tsunami, things like that. So the world population is getting older, basically because life expectancy is getting longer, medical care is getting better, quality of life is getting better. So currently, India has 8.5% of the population is 60 and over. But this elderly population time bomb is happening. The proportion is expected to triple by 2050. And 60% of new cancers and 70% of cancer deaths occur in people who are 60 and 65 and older. And as all of you go out into practice, so this number is going to increase. So all of you need to know how best to take care of older people with cancer. So by 2026 in India, there will be 4.5 lakh men and 3.7 lakh women with cancer in the 60-year and over population. In the hospital, I haven't updated this. This is older data. In the general cancer registry in the population, the proportion of people 60 and over is about 40%. So this is a pan cancer registry. In TMH, it is, this also I have not updated. So this was 2019, so this was pre-pandemic. So currently it's about 30%, putting it all together. And this was the DMG wise aspect this. So why am I harping on, why do you have this lecture on older patients with cancer? What is different about older persons? Sorry? More comorbidities, bang on. So what does that cause? If you have more comorbidities, what is the problem? Perfect. So more drug interactions, more toxicities, absolutely right. One very other important issue with comorbidities. Polypharmacy medication तो वही हो गया ना. Third one. Drug interactions. Yes. So that's all medication related. Something non-medication related. End organ damage. Yes. But that's not what I'm looking for. Compliance, frailty. All of this is correct. Sorry.
Worsening of the comorbidity.
Yeah. So that's part of what I'm looking for. So the problem with multiple comorbidities is every comorbidity is a competing risk of death. And that makes your treatment decision different, right? So if the person is going to die of heart failure or some other uncontrolled comorbidity, you should not be giving that patient the toxicities of chemotherapy, right? Because our goal is to make the patient live as well as possible and as long as possible. But if that longevity is going to be limited by something other than cancer, you need to be cognizant of that, and that's where the geriatric assessment comes in. So that's a very important reason. Any other differences other than comorbidities? Very good. Social support, make you absolutely bang on. It's a big issue. It is a little bit less so in our society because all of our patients come to our clinic with multiple people. But yes, social support globally is an issue. Any other issues? Cognition, yes. Right. So I have your paper as part of the publication. So I think in short, every organ system is affected. So as we get older, we are the sum of our parts, and all our parts become older, right? So I'll say this. So liver, you have decreased liver blood flow. So drug elimination is affected. Any drug that is hepatically cleared. Kidney, you have decreased kidney function, but also there's decreased muscle mass, right? So and your creatinine is reflecting your muscle mass. So your creatinine goes down, but the renal function is also going down, but you are not able to measure that, right? Because you're measuring the creatinine. So there's a falsely when you calculate GFR by Cockcroft God, it appears to be normal, although the patient's kidney is not normal. Then did you understand that? No, of course I understood minute. You don't not do this. The students will have understood that. So bone marrow, you have decreased reserve. Heart has increased risk of cardiovascular disease. There's loss of muscle mass because of sarcopenia, inactivity. So the problem is that all of this we all know, right? But the decline in all of these organ systems may not be obvious just looking at the patient. And that's where again the geriatric assessment comes in. There's also lack of functional reserve. This is this concept of resilience in geriatric oncology. So if or in actually for any of us, so when we have a stressful event in our lives, our resilience or our intrinsic capacity is what helps us to recover quickly. So that could be surgery, chemotherapy, or a emotionally stressful event or anything. So that is our functional reserve, and that goes down as age becomes higher. So kidney function we discussed, liver function we discussed. The distribution of drugs in or chemotherapy in the body. So as you become older, your fat content doubles. So it goes from 15 to 30%, but and your intracellular water goes down. Right? So there's an increased peak concentration of drugs which are water soluble because there's less for it to be absorbed in. And there's a decreased peak concentration but a longer half life. So because there's less fat content. Right? So there's a lot of differences in your drug metabolism at old age. So PKPD is a big issue. Absorption is less because there's atrophy of the intestinal villi, etc. So how do you assess the renal function? So on an average, the GFR goes down with age by approximately 1 ml per minute per year, starting at age 40. So once you've crossed 40, now, your kidneys are downhill trend. But anyway, so from age 30 to 80, your average GFR declines from about 130 in younger age to about 80 in an older person. So how do you calculate how's the best way to calculate your GFR in an older person? Right? Because I told you Cockcroft God, it's inappropriate because you are measuring creatinine which is generated by the muscle. So the best way is to do the weight, use the ideal body weight. So that would be based on the height rather than the actual muscle mass, and use Cockcroft God. Other ways that you might have seen patients who come to our clinic, we send them for what? DTPA. So DTPA is, we did a small study in our clinic. So in 110 patients, we calculated their kidney function both based on Cockcroft God as well as the DTPA. And so on the right side, you can see this is the red, between the green, so that's the range, right? So it was mostly in the same, it tracked together. The mean difference, I have to decline or allow? I have to change password, no? Okay, so the main difference was -4. So there was a difference, or this is between your calculated GFR and the measured GFR using the Gates method that the nuclear medicine. But there was a huge range. So if you can see these dots now, each of these dots is a patient's GFR, which is widely different from the calculated GFR and your measured GFR. So that affects, so overall in the sum of patients there's not a big difference, but in each individual patient, especially a patient who is being planned for platinum, so cisplatin or carbo, we'll be measuring the chemotherapy dose based on the GFR, and cisplatin is eligible to ineligible, so that's a huge difference, right? So platinum eligible to ineligible, 9% went from being platinum eligible to ineligible, and 20% went from being platinum ineligible to eligible. So the other way around. So it is best if you have the facility and the ability and the time to wait for a renal DTPA scan, it's best to do that. Any questions on that? So that is supposed to be the best DTPA by plasma sampling. We have done a study led by Dr. Vikram Gota as to what is the best in our patients. So that has completed recruitment. We haven't analyzed the data yet. So if you can do DTPA with plasma sampling, that's the best. If you can do serum cystatin levels, that is probably better than that. So I'll once that is ready, hopefully the slides for next year will change. But yeah, plasma sampling is the best. Any other questions on this? Okay, so great. So I think all of you all have agreed that we need to assess a patient differently, right? Or are there any dissenters currently? Okay, so why? So we'll assess them maybe a little bit more carefully. Do we need special tools? So what is this great geriatric assessment? Why do we need special tools? Can't we just look at a patient and see if the patient is looking frail or looking fit?
To objectify.
Correct, absolutely. We need to objectify. So this is the concept of that Aditya is telling us that there's a concept of chronological age. So when you see the patient and the patient gives you say age 70 or age 80, that's the chronological age, which is just the number of years that the patient has been alive. But there's a concept of functional age, meaning so an older person may be fitter, a younger person may be unfit. So the chronological age, number of years, while functional age is how the person functions in their daily life. And the functional age is what determines the management strategy in geriatric oncology. So aging is heterogeneous. Any of you want to? So the left side, how old approximately? So the men are similar age, the women are similar age. Sorry? What will I give you? Okay, yes, yeah. 65 is correct actually. 65 Sunny and 67. And right side is like late 40s. So I mean, Shilpa Shetty looks like a teenager. So the point I'm trying to say is that
just 1 second.
The others are not able to see it.